We've got two talks. First is from Professor John Fraser from Queensland. And he's going to talk about, or his talk is titled, "When is the Heart Truly Dead?" And he'll be presenting some information and background to an ongoing and a recent clinical trial for donor preservation. Thanks, John.
Chris, thank you very much for the introduction, and thanks to Sharon and the committee. It's lovely here in Brisbane. I hope you got the same weather down there. So I'll zip through this, but be aware that this is a team effort. It might take a village to raise a child. It takes a whole team to raise a transplant. I think everyone in that meeting knows. So the question really is, when can we continue to use the heart? We understand, and we listened to some great talks before, that the epidemic of heart failure is continuing, and that mechanical assist is fantastic and is developing. But the sad thing is that about 75% of organ hearts that could be used are discarded. So we have a large demand, which is why mechanical support is so important to us and to everyone else, but a very limited supply. And it's the act of brainstem death that we believe causes a major component of dysfunction of the donor heart. There's a number of different times at which the donor heart is impacted adversely, obviously the catecholamine in excess in brainstem death, but also inflammatory mediators as well. And this is from one of our previous review papers. There's systemic inflammation, neurohormonal dysfunction, and microvascular damage. And all of these compact even within the donor to make a number of hearts non-usable. When the heart is removed, the preservation of the heart is non-physiological. We try our best, but the whole procurement process and preservation is also associated with injury. And then to add insult to injury, transferring the heart into a frequently very, very sick recipient, and the recovery and the bypass, positive pressure ventilation, inotropes, etc., and the reperfusion. So a multitude of different smacks to an already damaged heart means that the injury is cumulative, and the older hearts we use and the more prolonged ischemic times and the more comorbidities makes it worse. So transplants changed hugely over the last 30 odd years, but the one thing that really hasn't until the last couple of years is how we preserve the donor heart. It's essentially a very Australian way of doing it, an escape with some ice. And within this, we understand that there's acidosis, there's dysfunction in the membranes, the membranes become dysfunctional, cells start to die, the endothelium and glycocalyx starts to die, and there's a lot of metabolic waste as well. So this means that realistically, we've probably got between 4 and 5 hours in cold static storage. So people have started looking at different machine perfusions. The device we've started looking at for a number of years is a hypothermic ex vivo perfusion. So HEVP, you're going to hear me about. Stig Steen, some of you may know of his lung rig, ex vivo. And he had done some nice studies in pigs without much biology to show that a heart could be transplanted after his unusual model of brain death, and it could be preserved for up to 24 hours, which is impressive. It's non-ischemic, it could preserve longer, and there was a specific mix of a hyperoncotic cardioplegia, but there's low pressure, low temperature to reduce the metabolic demand. This is a very simple schematic. It's not a particularly clever rig, which I think is one of its strengths. The donor heart is cannulated and perfused through the ascending aorta, kept in the cool in the reservoir. You've got 2 circuits, one for mixing and cooling, and the other for perfusing the heart. These are the different areas that you can see here. It's perfusing a heart, and this is what we created. Again, we used 2 old bypass pumps, but the functional part is exactly as Stig had designed it. Then there's a specific perfusion mix, which has got 3 main components. So number 1 is hyperoncotic cardioplegia. Number 2 is a brainstem death cocktail that has been developed. You'll notice that cocaine is on there. One time we didn't get the mix delivered, so I had actually to prescribe some cocaine from my own pharmacy. It's okay, I put it in Greg Scalia's name. And then the other thing is packed red cells with oxygen maintaining a pH around 8 degrees centigrade. So we went to our large specialized animal facility to develop a technique where we could improve the number of hearts that we thought would be transplantable, but also the quality of those hearts too. As I said before, this is a team of 80 people. So we have published before on our sheep brain death model. To make it as realistic as possible, we talked about where those injury periods are on the heart. So we have a sheep that's made brainstem death, and the brain death is declared at around 12 hours. And then that sheep is maintained as a donor for 12 hours. So it's just managed the exact same thing as a human, the PA catheters, central lines, you name it. But on top of that, it's got tissue microdialysis, it's got SDF, so we can actually watch the microcapillaries and microcirculation. So that's just managed exactly as would be. And then we had 3 limbs to the study, putting the heart on cold static storage, or the HIVP rig for 2 hours to compare, or for 8 hours ischemic times on the rig. We then brought in the second sheep, and that was a recipient, and that sheep was chest was cracked and was transplanted with the appropriate heart. And that sheep was then kept going for 6 hours post-op, so we could determine whether that heart was functional or not. As I say, standard clinical stuff with a vast amount of monitoring, echo, including speckle, contrast. David Platts is a great help there. Looking at the microcirculation, which we think is a massive, massive component at it. Being able to question the mitochondria, to look at the respiratory chain, and then inflammatory biomarkers too. Long story short, it's the ex vivo time. Not surprisingly, we could go up to, we actually went up in one case to 11 hours ischemic time on the rig, but the time in minutes was substantially longer. So cold static and the for 2 hours were the same, obviously. That's the clamp on and off total ischemic time. So just under 10 hours in this study, and the total bypass time. David McGiffin was our surgeon on this study, fantastic fellow. Would come up and down from Melbourne each day for this, and in fact isolated for 2 weeks at the end because we wanted to finish the study, and stayed with us for 3 months. So none of this could be done without David, or indeed the rest of the team. Long story short, sorry, this slide's not come across, but the HEVP rig improves survival and hemodynamic function. And it seems to be, and we didn't expect this, it seems to be that the longer it's on the rig, the better it worked. So we had 100% survival. Survival was coming off bypass with an adequate cardiac output. The HEVP improved the survival and the hemodynamic function. So again, these animals were managed a la ICU patients with intensive care specialists, cardiac surgeons, ICU nursing staff, and in daytime hours with cardiologists. So very similar to clinical practice. The HEVP, we thought were, and we showed this, was associated with much less vasoactive support. So the sheep with cold static storage had a huge amount of vasoplegia, a significant inotrope requirement. And you can see down here that it's much, much less on both of them, even at 8 hours. If we look at the lactate clearance, again, the cold static storage is far and away ahead, but between 2 and 8 hours, so quadrupling the ischemic time on the rig, and there was no change in arterial lactate. The base excess was much, much better with a P of 0.001 on the rig, and the pH was more stable as well. So, and despite having gone for 8 hours, the cardiac function, fractional area change in global radial strain, this is K. Sato's PhD, no difference even at 8 hours. Troponins, we saw that there was, we think there's a reduction in troponin, but it wasn't very, very clear in the study. Inflammatory mediators substantially down. Again, black is the cold static storage. So IL-6 was reduced, IL-10 reduced just below statistical significant. We didn't see there was a significant crossover here, but we think that there is a signal of reduced IL-8 too. We didn't see differences in TNF alpha. Looking at the endothelial glycocalyx, which we think is very important, we looked at a different number of markers. Again, the glycocalyx is the seaweed across the endothelium. It's important in terms of permeability, homeostasis, mechanosensory functions, and anticoagulation. So we're looking at this, and a hyaluron is one of the key markers that we've started to look at. It's very difficult to image the glycocalyx. We're trying with electron microscopy, but it's so fragile that just by removing it from the animal, it starts to shed. So we use markers for this as well. And what we're seeing is that it seems to be the glycocalyx is much less shed, even excuse me, on these small numbers. There's much less shed. One of the things that we could see on every occasion when you put the heart on the rig versus the heart on cold static storage, the urine almost invariably looked like this in the cold static storage. It looked like rhabdomyolysis, small volumes of black smoky urine, and every time the urine looked like this. We are pretty convinced, we haven't got all the data back to show that the kidney functions better, but we're pretty certain that the kidney functions better. And we think these are mediators that are essentially being washed out from the rig. Mitochondrial function, I won't go through this, it's maybe not everyone's cup of tea, but oxygen consumption using carbohydrates, the mitochondria work better, and LV and RV definitely seem to, there's no major differences between the two. Again, mitochondrial respiration, there's a potential improvement with the HEVP, but not so much with the left ventricle. So not 100%, but what we did see was each heart seems to work better. So it's definitely not inferior. We could go from the 2 hours to the 8 hours with better markers of inflammation, with inotropy, with acidosis, and these hearts were working well. I'll just show you, this is a video after 11 hours ischemic time, re-implanted, and it was on 0.02 of noradrenaline. 9 hours, 30 minutes, this one was. So in our vast brown land that is Australia, this is probably what we can do safely with airports and transfer. This is what we think we can do. And we also think we can use more hearts because the heart seems to resuscitate in the rig. Again, David McGiffin has been a stalwart here, as is David Kay and Peter McDonald down there. And with all the other transplant units except Prince Charles, we've now registered this study. This is what the rig looks like. So it fits on a normal business class seat. So the things that the cardiac surgeons are used to. We've now done 7 studies, 7 patients that have all gone well. Longest ischemic time, just over 7 hours, which is fantastic. Sorry, just over 7 hours, which is fantastic. And I'm just trying to, this slide seems to be lost. So look at his last slide anyway. And really just to thank everyone. This is a study that's running. I think we've now done a couple in Sydney as well. Auckland's up and running. Again, trying to teach people how to use the technology on Zoom has been a fascinating thing, but it's worked very well. So on behalf of the next slide, which is my entire team that have done the real hard work, I'd like to thank everyone on this team, and we look forward to delivering the clinical results at the end of this study. Thank you.
Thank you very much, John. It's very exciting. I think we've used the device in 2 patients so far in our clinical transplants, and certainly we're very excited at the prospect of the trial, and look forward to getting all the results together.